While public understanding of obesity's link to cancer risk is gradually improving, a more dangerous and less recognized truth remains largely hidden. Obesity doesn't just increase the likelihood of cancer, it actively fuels the aggressiveness of the disease once it emerges. A growing body of research reveals that excess adiposity creates a hostile biological environment in which tumors thrive, spread faster, and respond poorly to treatment. These effects make cancer deadlier in people with obesity and contribute to a disturbing trend: higher recurrence rates, greater treatment resistance, and lower overall survival. The tumor microenvironment in obese individuals is markedly different from that of lean individuals. Adipose tissue, particularly visceral fat, is not simply an inert energy reserve. It is a metabolically active organ that secretes a complex array of signaling molecules. In the context of obesity, this signaling becomes dysregulated. Adipocytes release pro-inflammatory cytokines like interleukin-6, IL-6, and tumor necrosis factor alpha, TNFA, as well as hormones like leptin and reduced levels of adiponectin. Together, these factors establish a systemic and local inflammatory state that supports tumor initiation, angiogenesis, new blood vessel formation, immune suppression, and metastatic potential. One particularly insidious mechanism is the altered metabolism of cancer cells in the obese body. Tumors in individuals with obesity are often more glycolytic, consuming more glucose, and they have greater access to energy-dense lipids released by surrounding adipocytes. These cells adapt to the abundance of nutrients in the obese microenvironment by becoming more metabolically flexible, more invasive, and more difficult to kill. Essentially, fat not only feeds the tumor, it trains it to become more aggressive. Treatment efficacy also suffers in obese patients. For one, obesity can alter the pharmacokinetics of chemotherapy drugs, leading to suboptimal dosing. In many cases, chemotherapy doses are calculated based on ideal or adjusted body weight, out of fear of toxicity, even though this can result in underdosing and reduced treatment impact. Radiation therapy, too, is more technically challenging in patients with high BMI due to tissue thickness, dose distribution, and positioning issues, which can reduce precision and efficacy. Surgical outcomes are frequently worse. Obese patients face higher rates of operative complications, wound infections, anesthesia risks, and longer recovery times. These factors often limit eligibility for curative surgeries, particularly in cancers where complete resection is critical, such as pancreatic or colorectal cancer. Perhaps most concerning is the mounting evidence that obesity impairs the immune system's ability to recognize and destroy cancer cells. Chronic inflammation drives a state of immune dysfunction. Natural killer, NK, cells and cytotoxic T cells, essential for anti-tumor activity, are downregulated or exhausted. The same immune checkpoints that immunotherapy drugs target are often more active in obesity-induced immune dysregulation. Ironically, while some studies suggest that obesity might initially enhance the response to immune checkpoint inhibitors, these effects are not consistent across cancer types, and the long-term impact of systemic inflammation still appears to tip the scales toward poorer outcomes. Even after treatment, the prognosis for obese cancer patients is often bleaker. Recurrence rates are higher, especially in hormone-driven cancers like breast and endometrial cancer, where estrogen levels remain elevated due to fat tissue aromatization. Weight gain during or after cancer treatment, common due to fatigue, steroid use, and reduced physical activity, can further elevate recurrence risk and complicate survivorship care. Yet despite all these dangers, weight is rarely addressed as part of cancer management. Oncologists may avoid discussing obesity due to time constraints, fear of stigma, or a belief that it's too late to intervene once cancer has developed. But emerging data shows that weight loss, even modest, can improve treatment response and reduce recurrence. Interventions like calorie restriction, exercise, and metabolic support are being actively studied as adjuvant therapies, not just for general health, but to directly improve cancer outcomes. Meanwhile, clinical trials continue to underrepresent patients with obesity, leaving gaps in our understanding of how best to treat this growing population. This underrepresentation is especially dangerous given that more than 40% of U.S. adults are obese, and globally, the numbers are rising fast. Failure to account for obesity in trial design, dosing strategies, and treatment planning risks creating a system that simply does not work for the patients who need it most. The truth is stark. Obesity is not just a cancer risk factor. It is a cancer accelerator. It is a treatment obstacle. And it is a survival threat. Every stage of the cancer continuum, from tumor formation to treatment to long-term survival, is worsened by the metabolic chaos, inflammation, and immune dysfunction that come with obesity. It is long past time for oncologists, policymakers, and public health leaders to recognize that fat tissue isn't passive, it's biologically active and often malignancy promoting. Obesity must be addressed not only in prevention campaigns, but in every phase of cancer care. Integrating weight management into oncology isn't a secondary concern. It is a frontline priority. Unless we act on this knowledge with urgency and compassion, we will continue to let an entirely modifiable condition undermine the effectiveness of our most advanced cancer therapies, and we will continue to lose lives that could have been saved.